An unresponsive patient arrives in your ER. They are barely breathing, their heart rate is slow, and their pupils are pinpoint. Clinically, this is a textbook opioid overdose. You run the standard 10-panel urine drug screen to confirm the toxidrome, but the results return completely clean. This disconnect between the patient and the lab is a high-stakes clinical blind spot. Drug screens rely on identifying specific molecular shapes like morphine's phenanthrene ring. If it fits the antibody lock, the test triggers a positive. Gas station synthetics have entirely different structures. The antibodies simply glide past the molecules without binding, leaving a false sense of security. In a modern ER, relying strictly on chemical testing creates a dangerous diagnostic gap. To save this patient, you have to look past the lab and rely on a specialized clinical assessment. To get the truth, you have to move past generic questions about recreational drugs. Most patients view these products as legal, natural supplements. Instead, ask specifically and without judgment if they use energy powders or liquid shots like OPMS or Zaza. The most common culprit is kratom, a chameleon drug with dose-dependent pharmacology. At low doses, it acts onto mu opioid receptors to cause profound sedation. While the raw leaf has a dimmer switch effect that limits respiratory depression, new concentrated extracts like 7-OH are much more potent. These massive doses act as full agonists, which shatters the drug's safety ceiling and leads to rapid respiratory arrest. Alongside these extracts, tianeptine is appearing more frequently in emergency admits. Originally an unapproved antidepressant, it is now taken in massive quantities to mimic the effects of heroin. Some users also turn to synthetic cannabinoids like K2 or spice, which carry a hidden manufacturing risk. Clandestine labs often lace these products with brodifacoum, a commercial rat poison. These over-the-counter supplements are actually volatile multi-system chemical storms. Identifying them quickly is the only way to begin the correct medical interception. If your patient presents with unexplained massive bleeding from the gums or GI tract, you are likely looking at the effects of that rat poison. It destroys the liver's ability to recycle vitamin K, sending the patient's INR skyrocketing. You might also hear a patient mention the wobbles, slang for the sensation of their vision physically jumping back and forth. Clinically, this is nystagmus, a red flag for neurotoxicity that requires immediate seizure precautions. When treating these overdoses, a standard 0.4 milligram dose of Narcan is often insufficient. These synthetics have an extreme binding affinity, meaning you'll need to anticipate orders for much higher or continuous doses to keep the patient breathing. There is also a unique aspiration risk caused by the toss and wash method. Users often swallow dry hydrophobic kratom powder that actively repels water. If that patient vomits, the dry powder mixes with gastric juices to form a heavy, cement-like paste. This mixture will instantly clog a standard Yankauer suction catheter, making airway management nearly impossible. Traditional bedside airway and reversal protocols are often insufficient for these synthetic cases. Preventing a secondary crisis requires you to have the clinical foresight to look for these specific physical indicators. Surviving the overdose is only the first step. The ensuing withdrawal is a dual system crash, a brutal combination of an opioid deficit and a massive adrenergic storm that floods the brain with norepinephrine. To manage this crash, you should advocate for gabapentin to calm the misfiring nerves that cause restless legs and clonidine to act as a chemical brake on the patient's extreme tachycardia and anxiety. Long-term recovery often starts sooner than it does with other opioids. Because kratom is a partial agonist, buprenorphine induction can often begin just 8 to 12 hours after the last dose. By looking past the clean lab results and identifying the specific toxidrome, you have moved from a state of uncertainty to complete clinical control of the bedside. Let's recap. Abandon the drug screen for a brand-specific interview. Watch for the wobbles and unexplained bleeding, and always anticipate a difficult cement-like airway. Legality does not equal safety. Trust your clinical judgment over a flawed drug screen. And hit subscribe to keep building your nursing superpowers. For more training and community support, visit us at supernurse.ai.